About the pain in 3 dimensions. Pain is not single fiber pathway. It has effect in every single part of the brain. I will show you that clearly. We'll talk about how the pain is spread of the world and how the United States affected by the pain problems. And briefly, I'm going to mention about the pathway of the pain, how the chronic pain develops, and then the role of the cultures, race, and ethnicity in the pain perception and response, and then what we learn, what we need to do as a pain specialist or provider dealing with the patient's pain. So when we try to define the pain, we found there's many definitions. The International Association of Study of Pain came with this well-adopted, well-acceptable definition of pain, which is unpleasant sensory and emotional experience associated with actual or potential tissue damage, or in the same such damage. So this is the International Association of Study of Pain definition. The psychiatric definition of pain came to say is a conscious aversive aspect of somatic awareness, product of complex central nociception-induced processing and not primitive sensation, as we thought in the past. And the sociology, anthropology, psychology came with a different aspect of pain with the nociception. Nociception is the feeling of pain environment. It's not only the pain sensation, it's what did the pain affect the whole milieu of the person himself. So nociception is a nerve conscious and engaged sensory, emotional, and cognitive process area of the brain. So all of this lies in the pain definition. And as you see in this picture, there's a lot of identifiable area of pain, but the most important, the projection of this picture would show that the suffering of pain. So when you see this picture, you feel patient is suffer. It's not only feeling pain, it's suffer from that. And suffering is part of the important part of the pain itself, or pain story. And if you see this diagram too, it shows that the tissue damage is small circle of the pain problem. Actually, the pain sensation is a little bit more, though the thought, emotion, suffering is the big circle of the pain problem. So when we deal with the patient's pain, we're not dealing only with sensation of pain. So we're dealing with how the pain affects the life of this person. So we need to concern about the many aspects, functionality, other aspects too. If you go statistically, we found that the pain in the United States, we have about 16 million person in the United States suffering from chronic pain. That will cost the country about $630 billion a year. And this is 7 years ago statistics. Now the situation is even much worse. There's another view of that is actually the people who are suffering from pain is 300 million people in the United States. This is acute and chronic pain, but the chronic pain is only 116 according to this data. The good news for us is we have only one pain specialist for 33,000 patients. So we have a lot of business to do in the future for this patient. So to talk about the pain, we're starting from top to bottom, or from central portion to the periphery. And when you talk about the center portion, we need to know about the pain metrics, the brain pain metrics. And when we start to get the MRI, function MRI, we have more information about where the pain goes in the brain, where the centers of the brain that's stimulated when the pain stimulus happens. And actually, If you see here, we divided the pain metric, divide the location of the pain area in the brain in 3 main areas. The sensory dimension of pain, we feel the sensation of pain only, and the affective dimension of pain, and the cognitive dimension of pain. And actually, we made this separation. There's no separation. All these centers work together at the same time and interact at the same time to create the situation of the feeling of pain. And this is, I like this video that will tell us how many areas of the brain being stimulated when the pain stimulus happens. This is not in sequences, but it's by location. That doesn't happen amygdala to other part. But this is the location only. And as you see, amygdala is one of the big area of the pain centers and carry other function as well, not only the pain. Insula, also another part of the brain that has been consistently active or activated with the pain stimulation. And this is big area of pain center as well. Prefrontal cortex is involved in the pain modulation. The cingulate gyrus, both anterior and posterior parts. Even the parietal cortex, we never thought this is involved in pain. It has actually stimulated with the pain stimulation. So this became an area that associated with the pain pathway. Somatosensory, we know that long time, and actually the prime motor area as well has been. So as we see in these pictures or see this video, most of the brain centers has been involved in the pain process. That's why we say it's a very complex phenomena. And this is I passed this because we saw that, sorry. How did it go back here? If you go to this video, let's tell us the story of pain. From where the pain starts, where it goes to the brain, what area that's stimulated, and what area is trying to control the pain. This is one of the examples of the pain origin. And that's once it's stimulated, it releases a lot of mediators. We're going to talk about that shortly. And this is stimulate the spinal cord dorsal horn, spinothalamic tract. That goes superior to the higher center of the spinal cord and the brain. In different phases. We're going to talk about that briefly. And as you see, the video is mostly every single area of the brain has been stimulated. Even the cerebellum now. Cerebellum became pain centers. That was not identified in the past, but we found the cerebellum has been activated with the pain stimulation as it goes. And there's a very nice way of treating the pain is to control the cerebellum activation, and there's some technique for that. And as you see, the stimulation happens, the brain tries to combat for that, try to antagonize that by different mechanisms called anti-nociceptive pain, and I will show you that very quickly. As we talk about the cingulate gyrus and the amygdala and the hippocampus, this is the limbic system. The limbic system in the brain controls a lot of actions, one of them the pain. And the affective part in the human being is controlled by the limbic system. And this is the part that culture and race work through to affect the pain response. So there's a link between the pain and culture through this affective limbic system, or the affective center of the pain. So if you go to the basics anatomy, the pain starts by the sensory discriminative dimension, the simple stimulation. When you get hurt or get stimulus to your tissue, three processes happens: the transduction, transmission, and modulation happen in the periphery and central nervous system. In the periphery, transduction is change the stimulus from chemical, mechanical, thermal to electrical stimulus that action potential develop, create the impulse, go to the central nervous system, and you feel the pain. As you see in this picture, that in the healthy tissue, the fourth structure here is important for us to identify: the fibroblast, mast cells, the nerve endings, and the blood vessels. When the injury happens to this tissue, this structure release mediators, allogenic mediators. And these allogenic mediators stimulate the receptors and create the pain signals. And there's many of these mediators. The one we know for now is the neuropeptide CGRP coming from the nerve endings. The north growth factors come from fibroblasts, the bradykinin from local circulation, and the histamine and serotonin from the mast cells. All these mediators identified now as a pain mediator that start the pain pathway. And this is some of the receptors this mediator works. There's too many of them that we know now, but there's more discovered. And from the receptors, we call it nociceptors, the signals or the action potential of pain goes to the first order neuron, dorsal horn cells, and go to the dorsal root ganglion, and from there go to the lamina in the spinal cord. Here it's worth to mention that in the spinal cord there's too many lamina. We're talking about A beta fibers, A delta fibers, and C fibers. The A delta fibers and C fibers are the fibers that carry the pure pain sensation. The A beta fibers usually does not contribute to the pain sensation until there's some chronic disease problems or there's things change. The A beta fibers start to carry the pain sensation. And that can explain the allodynia. Allodynia means non-painful stimulation produce pain. When you have a surgery or have wounds, if you touch the wound, that hurts. The touch carried by the A beta fibers. Usually it does not hurt, but in this pathological situation, it hurts because the A beta fibers change the location and start to arborizing or start to sprout in the pain center of the dorsal horn cells, which is mainly the area 1, 2, and 4, and 5. This is where the pain transmission happens. The other two fibers with the A delta and C fibers, actually, they rely on the A lamina, lamina 2, and lamina 5, which is the main lamina that concern or at least contribute to the pain pathway. As the pain develops or the pain signal goes to the central compartment, the brain starts to antagonize the pain feelings by another pathway called anti-nociceptive pain pathway. And another fiber is projected from pre-aqueductal gray matters in the midbrain to the locus ceruleus, the ponus, to nucleus raphe, ending by the dorsal horn cells. So the brain tried to antagonize the pain, the brain itself tried to antagonize the pain pathway by sending another mediator to the dorsal horn cells, and they all meet in the gatekeeper. The balance between them, that's the intensity of pain you feel. If the impulse of the pain stimulus is so strong, you feel more. If it's less, the antinociceptive pain pathway will control it. And this is the antinociceptive pathway. The mediator there, or the transmitter there, is serotonin and norepinephrine. And that's where the same pathway or the same mediator for the depression or the other psychological problem. That's why when we use the antidepressant medication for patients with pain, we're aiming to enhance or stimulate the antinociceptive pathway. It helps us in pain control. It helps enhance the antinociceptive pathway to control the pain. We're not aiming to treat depression with this, though the higher dose of this medication can help depression as well. And here is this is an acute situation. Acute pain, what happens is all this area has been stimulated by the pain impulse. The body tried to antagonize that by releasing a lot of GABA. GABA mediator, GABA transmitters help to soothe the pain and control the acute pain. And that's a very natural process. If you hurt yourself, you hurt immediately, and then the pain goes away. One of the reasons of that is the brain will release a lot of GABA to control the pain impulses, and the pain will go away. That is if it's brief, acute pain. Chronic pain is a different story. We're going to talk about that. So this is briefly the pathway for acute pain or the pathway of pain in central nervous system. How the development of the chronic pain, how the chronic pain develops, and what enhance, what the mechanism for that. I'm going to mention that in also this video might be a good introduction for that. Just be patient. I like the second part. Here you see that all this effect of pain ended by the affective response to pain. In chronic pain, the affective response is very high. As you see here, the chronic pain, there's increase in intensity of pain. We have consistency of pain with anxiety and depression. That's as a development from the chronic pain suffering. And that's part of the problem. When we treat these patients, we're not treating the pain, we're treating the whole suffering of these patients. Right. So when we talk about the chronic pain, we talk about syndrome of multiple central nervous system dysfunction. It involves the sensory, affective, and cognitive. So we're no surprise if these patients suffer from depression and anxiety, isolation because of the chronic pain. The change happening in CNS because of chronic pain, we call it neuroplasticity. And we are going to mention about that in brief shortly. When we treat a chronic pain patient, we are not expecting to cure this patient. We're expecting to control the pain, improve the functionality of this patient. And there's no way one person or one specialty can improve a chronic pain patient or increase the functionality for that. It needs multidisciplinary approach for these patients. How the chronic pain happens, there's a peripheral mechanism and there's central mechanism. The peripheral mechanism, we can attribute that to the tonic activation of the C fibers. There's either inflammatory activation or neuropathic activations, as there's a continuous bombardment, continuous discharge of pain impulses in periphery. It will stimulate the central compartments, and a lot of change happen there. In the inflammatory pathway, we know there's inflammatory mediators, but in the nervous pathway and neuropathic pathway, when you saw neuropathic pain like people with peripheral neuropathy, the mechanism is different. The peripheral nerve in the neuropathic pain of peripheral neuropathy is the pathology there. The peripheral nerve, for some reason, either traumatic, ischemic, or chemical, any injury to the peripheral nerve, led to two things. Led to increase the sodium channels across the fibers and the dorsal root as well. When you increase the sodium channels, the action potential can be spontaneously developed. The pain can be created by itself and maintained by itself. The same thing happened to the sympathetic sprouting, sympathetic nervous system. Excessive noradrenaline receptors develops, and when a lot of receptors develop, the sensitivity reduced, the threshold reduced, and the spontaneous pain can develop as well. So the people with the chronic pain has spontaneously discharge of the pain impulses. That's in periphery. In central compartment also became changes. There's a lot of change happen in the spinal cord and happen in the brain. In the spinal cord, in dorsal horny cells, in the chronic pain, I'm trying to compare between what happened in the acute pain and the chronic pain. This slide is a very genius slide. It's a simplified slide to tell you in acute pain what happened in dorsal horny cells, and on the right side, what happened in the chronic situation. In the acute pain, when the acute impulse happens of the pain, it led to release of a lot of glutamate excitatory mediators. This excitatory mediator, glutamate, go across the cleft of synapses, stimulate the AMP receptors, and the AMP receptors open the channels so the propagation of the impulse develops. This receptor, the AMP receptors, try to stimulate or to activate the NMD receptors, which we think is the receptor of the chronic pain. But in acute situation, there's not enough time, not enough mediator to get the NMD receptor activated. So it will not be able to do that, so the acute pain will terminate at this level. In the chronic situation is different. The glutamate released continuously, so the AMP receptors continuously activated. And by now, the AMP receptor were able to activate the NMD receptors, which is, once these receptors start to be activated, it will stay activated for a longer time and allow a lot of calcium influx, protein kinase C stimulated. And when this happens, a lot of intracellular change occurs, including gene production, to maintain the process of the action potential of the pain pathway. So the difference here is the activation of NMD receptors by the continuous stimulation from the glutamate or the excitatory mediators. We'll pass this. what happens with the continuous stimulation of the central nervous system, spinal cord and the brain. Spinal cord, what happens there, the NMDA receptors upregulated, so the sensitivity increases, be able to recruit more of these receptors. The GABA receptors downregulated. The GABA receptor is the anti-nociceptive pathway, so that would be goes down. And the inhibitory neuron activation is reduced. The anti-nociceptive pathway reduced. Somehow it's inhibited. So the dorsal nerve cells discharge more impulses to the central nervous system. And as the time goes, there's a gene start to develop that's maintain this process to happen this way. So conclusion of this effect is decreased threshold of pain stimulation and dorsal nerve cells. It's easy to stimulate. Amplification of the pain impulse or pain signals in the spinal cord and the brain. And these chronic pain patients start to have pain all the time and suffer from that. In the brain, what happened in the brain? The two phenomena I like to mention here, which is interesting for us to know. The excitotoxicity and the neuroplasticity. There's many other phenomena, but these two phenomena are considered new to us. The excitotoxicity, that continuous bombardment, continuous release of glutamates will kill the cell over time, and the new cell will develop. The new cells will develop only for pain. The pain cells or pain receptors develop. So there's exaggeration of development of the pain receptors in the center, in the brain area. The neuroplasticity, which is another interesting area to mention, and this is, by definition, is the ability of the brain to form new connection. As the pain continues, the brain is stimulated, and the brain starts to have more wiring between the centers. And this wiring will be mainly with pain receptors. So we have increased the pain receptor in the brain. So the synapses increased, and arborization increased, the synaptogenesis increased. And this is one of the very interesting video to watch, which show you what happens in the brain. Just it takes a minute. So this is releasing of the substance P or the mediators peripherally, stimulate the brain, as we saw that in previous videos. So this area that's being lined, the area where the ability to make new network. This is the regular impulse. Now we start to develop new wiring, new connection to make more receptors, more impulses, more mediator release. And these receptors and mediators, the pain receptors and pain mediators, that's in the brain. So the brain became more infested, having more pain receptors. And that's maintained the feeling of pain with the chronic patients. This is in the excitatory phase. As a pain guys, we need to treat this phenomena. Once we try to control the pain by different modality, pain medication, spinal cord stimulation, this excitatory phase will reduce, a stage of inhibition will develop. So the wiring happens where it retracts. And then with the CBT and psychological and all this training, the unlearning of the brain develops so we can get rid of this impulses or new receptor, new wiring, and the patient can improve. That's why the CBT is good modality of pain control. So we mentioned all of that just to give introduction about pain. How the culture and pain react together. As we said here, the effective portion of the pain is coming from the limbic system, cingulate gyrus and its other centers, prefrontal area. The culture, by definition, I just passed that, okay. The culture, by definition, is beliefs, and we go for that. The beliefs and feelings and history is controlled by the limbic system and the cingulate gyrus. So if we talk about the culture, we talk about these centers that have been affected by this. Here in the United States, we have a diversity not existing anywhere in the world. As you see, this is the map of the United States. You can see how much diversity we have. As a healthcare provider, we need to understand that. We need to treat our patients by understanding what is the background of that. It's a hell of work for us to understand and to work, but we need to work with this. Right? The second generation of the immigrants, you don't see much diversity, you don't much difference in the culture. Became somehow in one culture. So the first generation, like me, is what we have difference, we have issues. The second generation will be much less. And so we can manage this generation more than can manage me. And the same thing that if we see ourselves in the United States, we have all colors, all feelings, different frameworks. So that has been in one unit. And our job is to make this diversity tolerable to the different people. Regarding the pain is the same in every culture. Any culture we have, they have pain. They cry, they suffer. There's no issues, there's no difference between white, black, yellow, Oriental, Middle Eastern, Muslim, Christian. There's no difference. Pain is the same. Everybody is having pain. And even the alien come to the United States, they suffer from pain. And this is a very nice cartoon to show that also. Every single language, every culture, the language expresses their pain. French, English, Arabic, any type. So everybody has pain. As you see here, this is the repeated slides. The pain itself, the sense of pain is a small circle. The big circle is the culture influence response to this pain. So what the culture? Culture, as we see here, is the beliefs, behaviors, attitude, expectation, and tradition. All this lies in the culture. All this influenced by the central and the brain parts. The factors that influence the culture is either dynamic, something can be changed over time, and we see that in first, second generation. As you stay in the different country for a longer time, you gain this part of the culture. But the culture that's hard to change is the religion, ancestry, language, skin color. You cannot change that. It's very difficult. It's very few people convert from religion to religion. Very few people, they can deny their ancestry. Very few people can change the skin color. So this is not changeable. And here in the United States, or in many places, big part of the culture is the religion. So all type of religion exists, and they work together. And we need to accept that as we treat our patient, actually. In one period of time, the anthropologists tried to make a unit of culture corresponding to the unit in physical change like gene. So they call it memes. And they define the memes as this is the unit of behavior evolution. You can see the change in the culture. You can see change fast, maybe hours, maybe days, maybe years. But in the other side, the genes, you cannot see that easily. The mutation happens in hundreds of years. So there's big difference between the physical gene evolution and the culture memes evolution. When we talk about ethnicity, we talk about the social group that have common religion, language, and distinctive cultures. They have their own cultures. So we say ethnic group, that's what we mean by this. When we talk about race, we talk about the people, they have common ancestry, distinguished from others by physical characters like hair, skin color, eye shape. And anthropologists divide the whole world in three groups: the Caucasian or Caucasoids, the Mongoloids and Negroids, and there's a lot of mix between this race type. So race, ethnicity, and culture is all interact with the pain in different ways. Are going to mention that. So in clinical life, in real life with us as physicians, what we see. As I go, the definition of pain will, there's a lot of statement to define the pain meaning as we go with the culture surveys. So here, the pain is a biopsychosocial phenomenon. Psychosocial components strongly influenced by the culture, which is very right. Perception of pain, response to pain, pain behavior is influenced by culture. So the culture affects all these things. Professor Chalk in 2012, he have a very interesting statement, and he considered pain as a subjective personal experience influenced by the cognitive function affected by sociocultural factors. So that's now the culture affect the pain, and the pain affected by the culture. And this has been stated in many other studies too. Different people with different culture have different presentation of pain. Clinically, we see that. So it's not far from us. Even identical symptoms could have a different presentation with a different culture people. So if you say that Middle Eastern person can present different than the American person can present, even the pathology is identical. Same problem, same pathology, but different. And we see that too. Treatment, response to treatment, it has little to do with objective physical findings in different culture. So the presentation is different, the response to the pain difference, response to treatment is different. That's all has been documented. This is some part of the slide is not seen, but in general we found that 33 of people that has clinical significant symptom consult physician. What happened to the other 66% of the people? They have different way to present their problem. So culturally controlled. Not every person run to the physician to complain. There's a lot of people who do that. I see patients every day. I have patients come to me every week for the last 5 years. I have patients don't see after once a year and have significant findings. So this is not unusual to see. 30 to 50% of people go to primary care physician they treat it with unidentifiable diagnosis. Symptoms, we treat it. We don't know what, we cannot find the reason. And 80% of people with back pain and headache, they have no physical findings. So this is all controlled somehow. So with this survey or the study show that we adapt few things here in our culture modified treatments. We say pain is a subjective perception, results from sensory pathway, transduction, transmission, and modulation, filtered through personal genetic composition, filtered through learning history, filtered through or modulated by psychological expectation, mood, and idiosyncratic appraisal. And all of these factors controlled, or at least influenced by the culture and ethnicity and the race. So the culture affects all these items. So socio-culture, environment, self-body, pain is composed, highly interactive, emotional, cognitive. So this has been shown that all these items, the culture has big influence, and that we see actually, frankly, in our community of patients. Patient mood status difference in different times come with different complaint, all of that. Here in this patient has person every single part of his body. He doesn't complain of pain. He's motivated to do that. So the motivation or psychological status control the response to that. And I get a lot of patients coming having tattoo from the head to the toe. Every single part of the skin, there's no place to do another tattoo. When I offer him injection, he said, I'm afraid of needles. He doesn't like the needle. So that has been play a part, psychological elements, which is controlled by the affective parts, controlled by the culture and beliefs, can affect the pain response. But we found that across the cultures, we found that when the person say, I have pain, this is the intense word. When they say, I'm hurting, that's less intense. So there's some common between cultures in their expression we can understand to identify the degree of problem or degree of the pain they have. Catherine Lash, she had PhD thesis, and I quoted this from her thesis. Culture influenced person perception of pain. With increased number of immigrants to the United States from non-traditional region, we are facing that cultural diversity. And with the cultural issues, the management of pain has changed as well. It should be considered. They found that the people, in general, the pain is not well treated, but the people that suffer the most are the minority group, African American group, and the Native American. In her study, her PhD study surveys show that. So that's the time for us to consider this as a problem and we need to solve it. This study with Kleeman and his groups show the barrier for when the pain experience affecting the population is the illness beliefs, the behaviors, attitude, healthcare practice, medical care intervention. All this could be helpful, could be barriers to get the right treatment. Also, he commented that the Western trained physician, he looked the medical care as highly sophisticated technology. Should cure the problem and ignore the personal parts, the human parts. And that's another problem we need to face. People with different culture different background, they have different view for the hospital stay. They don't like to go to the hospital because they might die there. They like to die in the hospital. And my parents did that. When they get sick, they refuse to go to the hospital and they died at home. They don't like that. And this is very real. They have a lot of doubt about the diagnostic value, X-rays, MRIs, lab tests. Don't care about that. A lot of people, especially the first generation or older people, they look to this way. And the concern about we take a pain medication for pain, that might be addicts, might be side effect, might be a problem. There's another barrier of that. In the survey, it shows that all the cultures, they have the same, almost the same threshold of pain. They feel the pain the same threshold. Only the response to pain is different. So when you do the test for the pain, yes, I feel pain now. But one scream, the other one is okay. So that is, the other culture feel that. The problem coming from what comment on this pain. The studies show here in African American and white American, the African American report pain is more intense and pleasant than the white or Caucasian. They feel it more intense for them, even the same threshold. The same thing, the East Indians, they tolerate pain more than the Western or the American white people. There's another survey is done in 2012 with different questionnaire. The expectation, they study the sensitivity to pain, the pain endurance, and the willingness to report pain. And they study that in elderly and the gender as well, and a different race group. So this is not a pain-induced survey. It's just they went outside and asked the people, what if you feel pain, you represent that, to report that immediately or take time. So what they found that sensitivity to pain, to report that is typical white is the first people, they will be first people to represent that, report that, followed by the Hispanic and typical black. The willingness to report the pain immediately is the white people more than the black people is. Age, as we study in our pain specialty, we say that the age people, the older people, they don't feel pain as much. But in this survey, they found that the old people are willing to present the pain, to report the pain more sensitive than the younger people is. So this is contradicts. So the question is the tool we study the pain in elderly as reliable or not? So we need to review that. And in this questionnaire, the male person has more endurable, less sensitive, and less willing to report pain. I don't know if this is true or not, but this is what the survey said. Okay. Chronic pain is better way or better model to see the effect of the culture on, because it is stable status of pain. Acute pain is less. So the chronic pain affect the mood, thinking, which both controlled somehow or influenced somehow by the culture. That might lead to the anger, anxiety, and depression. All of these affect influenced significantly by the culture and beliefs. Cancer pain as a model for the chronic pain, it shows that in this study, there's a big culture influence in pain between the Western and Eastern Europe population. The Eastern Europe population tolerate pain more than the Western population is. Kodiak in his study, which is very important part, mentioned that when the patient has a meaning of pain, he will tolerate the pain. If the patient does not agree he should have pain, he cannot tolerate. He'll be very unhappy with what's going on with them. Another study in chronic pain, secondary rheumatoid arthritis, it showed that the white versus the African American, the difference in pain beliefs, pain perception, different pain coping strategy between the two groups. And the study on the Mexican American dealing with childhood illness, stronger religious faith represent very powerful coping strategy to treat the pain. So the religions can affect response to pain, and let's go to the culture as well. I should mention this earlier, that pain behavior, they divide the people in two categories. The first category is called stoic response, or stoic category, stoic patients, and emotive patient or emotive response. The stoic people or patients are the people that's introverts. They take things inward them. They believe pain is a private and personal experience and tend to withdraw from the community. These people is more found in the Oriental or Eastern population. Emotive response, people that can express themselves verbalizing very, very obviously and very clearly. This is more of the Western type of culture. It has been suggested that the Western culture, the Eastern culture endure pain more than Westerns. The Western culture in the survey showed that pain is bad, not to be endured, should be terminated. So they have no endurance, tolerance to pain. This is another study which reverse what I've been saying earlier, so that average white American tolerate pain more than Oriental. There's only one survey. Blacks in the middle, minority group report higher level of pain. I think the coming few slides the most important part of this talk. So endure with me for 5 more minutes. So the researcher tried to find a reason what could be make this pain difference across the culture. So identified some factors, biological, social, and psychological factors. The biological factors, a very small study happens with comparing the African American and the Caucasian patient that's going for cardiac cath. They start with the hemodynamic response to the pain during the cath, and they study the endorphin levels. They found that the African Americans, they have extreme response to the pain from cath with the hemodynamic change. The Caucasian and the white Americans has much less response to the cath pain. And they found that the white Americans, they have higher level of endorphins compared to the African Americans. So they found this may be one of the reasons why the white American more tolerant to pain than others. The social factors, which is an important factor for us to consider, is the inequalities in social and economic condition affect the culture of people that play a role in the pain response and pain reactions. The ethnic minority have less option for pain management modality. They don't take more medication treatment. They have no access to the health care, and they suffer more from pain. They found also that in a study, the Hispanic take the least amount of medication consumption in the hospital compared to the European whites in the hospital with the same surgery. Education resources. The minority have less education resources than the others. So they have less education level. When you have a less education levels, they found that disability with the people with less education is higher than the people with higher education. When you have a less education, you have less job chance, so you work in a hard job physically, so you are exhaust your body, and we found that back pain is much higher in the people with lower job, lower education because of lower job. So these people are exposed to pain more than the other people because they have no resources. At least they don't have the same opportunity for education. The racial and ethnic discrimination exists in different places. That will be psychological distress for this population, sympathetic stimulation, exhaustion or fatigue develops, and they have less tolerance to pain. Also, there's a very interesting study comparing the African American and white American regarding their strategy, coping strategy. They found the people with the African American, they use more social support, distraction, diverting attention, praying and hoping. The white American, they use more ignoring and self-statement. So this is the coping strategy is one of the most important mechanisms to deal with pain. Meaning of pain. If I feel I'm a victim of pain, the response to pain management is much difficult. If I feel the pain I can't control, so you'll be able to work nicely with these patients. And this is the CBT, actually, when send this patient to psychology, try to get them to this level. This is pain, you can control it. You'll be able to live with some degree of pain. This is the way the CBT works. So I'm going to conclude this long talk in the coming 4 conclusions. Number 1, culture is a framework that directs human behavior in a given situation. You can see the person react differently in different situations. And I see that in a patient. We call the patient schizophrenic. Is not schizophrenic, but the mood change. One day the patient comes to me very happy, very pleased what I'm doing. The other day he's very unhappy with that. Meaning and expression of pain are influenced by culture. Physiological response, tissue stress, emotion, behavior activation depends on the experience and perception. People respond to pain divided in 2 categories, stoic and emotives. As a pain physicians, we cannot differentiate in treatment between these 2 personal differences. We have to treat both the same. A lot of patients, stoic patients that do not express themselves enough, might not get as equal treatment as the patient that make noise about their pain. So we need to learn that, and we need to appreciate the people that do not talk much. They need to have the opportunity to get the same degree of pain care. Conclusion 2, you should not assume pain experience. As I said, stoic patient does not express. So cannot say if it's not expressed, you don't have pain. Don't assume pain experience is the same across the culture. I'm from Middle East, I don't feel as much pain, so everybody has to be the same like me. No, we have to appreciate the individual culture. Not to assume our reaction to pain is normal and the other people's reaction to pain is abnormal. That's what we need to learn from the cultural diversity. Conclusion number 3, do understand people culture. Do pay attention to that. do study them. At least do appreciate this difference. How ourselves as a provider, our pricing affect our attitude towards pain. We're talking about ourselves now. The way we are raised, how that's going to affect the patient with pain. Do we, as a care provider, understand our own culture? Are we stoic individuals? I am. Are we emotive individuals? Many others. Do we know how to deal with the opposite type? Because I'm a stoic person, I don't like the emotive person. I should teach myself not to do that. Many discount the pain suffering when there's mismatch between the injury and the verbal expression. Many times I don't find a reason for your pain. It doesn't mean the patient does not have pain. If you cannot find the physical findings, does not exclude the patient from the right management. The last conclusion that physicians, nurses, and therapists have to be culture competent. How we do that? We have to be aware of our own culture, values, family value, personal biases, and assumption. And we have to accept the cultural difference, understand the dynamic of the difference, adapt to diversity, listen with empathy to the patient, to offer same treatment for all patients. And here I say, thank you by all language you like. My language is shukran, but you can choose the language you like and follow that. We agree with all diversity of culture. Thank you.